First is that, as I said, that belongs to the last century. Can we move on, please? Thank you very much. You know, it's sort of a special occasion for me. I'm sandwiched between two people that bring me immense joy. I'll start with Nandita because I know Nandita from the time that she walked into a classroom and she remembers that I walked into the classroom biting into an apple in my hand. And, I've seen her grow and you know, the greatest joy for a teacher is to see your student better. And that's really all it is. Georgie, I think, so I came back wet behind my ears. Georgie took me under his wings. He even paid for my wedding honeymoon. And I should tell Vishnu because she's here. And I'll tell you something, the only thing, I won't tell you anything more than this about Georgie because that will tell you who this person is. He came for our wedding in Tirumala. And we had a darshan. Georgie wrote in the book that he believes in Narayana. Started saying Narayana, 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 all the way into the sanctum, came back the same way. The first time I learned how to touch a patient's hand and reassure it is way before I went to the US and came back. In 1987, Georgie was in Tamil Nadu hospitals. I came there looking for some exposure to medicine and he said, "Hey, yada." You see that. And then he took me to a patient, took the patient's hand in his hand, gave it a nice rub and said, "How are you doing?" I'll tell you something that changed my life. And I'm a changed person because of Georgie. Thank you, Georgie. Please give him a great hands. An amazing human being. Forget that he's a great doctor. He's an amazing human being. Let's go to this. Next slide. Want me to do the slides? Yeah. So, I keep talking about moving from diabetes care to metabolic care. Right? Why am I talking about moving from diabetes care to metabolic care? Some of you must have read the editorial Dr. Mohan and I wrote in Journal of Diabetology about this. One, they come in the same soil. Second, one feeds on the other. Third, addressing obesity, which is before all of this, takes care of all of them. The management of one impacts the other. And the drugs that are used for one condition impacts the outcomes of the other. So I think most of us who practice diabetes need to upskill ourselves into metabolic medicine. The next time, hopefully, I do a master class on metabolic medicine. I hope I can do that in this part of the world with colleagues. But this is something I want you to think about. Move away from. So today it is CRM, tomorrow it will be HCRM, hepatocardiorenal metabolism. Then it will become NHCRM, neurohepatocardiorenal metabolism. But ultimately the patient is one. This is a new criteria of CKD. It's been so 10 years ago, all of you learned to use the EGFR, right? We kept talking about it everywhere. Two things to use: the EGFR and the urine microalbumin. Now, in my mind, see, at Georgie's stage, it is CKD, end stage, dialysis. But for me, I start thinking of patients as: is he an A1G2, A2G2, A3G3? I actually write this in my case score. Why do I do that? Because it helps me understand that this is the target organ damage in the patient. So if you look at this side is the albuminuria. This side is the reduction in EGFR. So when you write your case sheet, if you have someone whose EGFR is 70, and who's, remember, a creatinine of 1.1 could still be an EGFR of 60. So be careful. Don't go by creatinine. By the way, how many of you have ChatGPT on your phones? Everyone should have it. Why? You don't need an app anymore. Put in the creatinine, put in the weight, put in the height, and say, "Hey ChatGPT, give me the EGFR." And sometimes I tell it to shut up because it writes a calculation each time. Display the result without the calculation. It'll do it for you. But learn to start using AI in your clinical practice. Right? So this patient will be A2, G2. A3, G3. So clearly, these two things are really, really important. When people talk about EGFR less than 60, remember that 60 to 99 is already a G2 disease. Got it? Let's go on to the next. So, what we know is, why is it that cardiovascular disease causes increased renal mortality? Very simple. Endothelium. Right? Both have tremendous amount of endothelium. The changes in the endothelium that occur are in both. And therefore, one affects the other. If you have heart disease, it's very likely you're going to have kidney disease. That is why microalbuminuria is a greater predictor than cardiovascular disease than anything else except smoking. Right? Second, if you have kidney disease, your cardiovascular outcomes are worse. So, all that this tells you, and I want you to look at this third bit that we have ignored for many years, that is heart failure. Again, how many of you measure NT-proBNP? It's not for today, but how many of you measure NT-proBNPs in your practice? 3. Next year it must be 300. Right? Echoes are technician dependent. NT-proBNP is a marker. And today we use a cutoff of 125. Any patient with heart failure stage A, which is all your diabetics, I measure NT-proBNPs every year. And we just had a publication in the ADA, we just had an ADA poster that's getting published. We looked at patients, cross-section, 3,500 patients, less than 1 year, less than 5 years, less than 10 years, greater than 10 years. By about the 10th year, your EGFR comes down. By about the 10th year, you move from A1 to A2. By about the 10th year, your NT-proBNP goes up by from 120 to 117 was our average to 220. By 10th year, your FIB4 score, how many of you calculate FIB4 scores? Again, all of us need to start doing it. When you calculate a FIB4 score, it goes away from 1.17 to 2.2. That's what 10 years of diabetes does to you. Okay, so here's a patient, 50-year-old woman, hypertension, dyslipidemia, BMI of 30, start measuring waist, start measuring hand grip dynamometry, start measuring calf diameters, hemoglobin is 9, HbA1c 7.9, lipid profile, LDL is already 102, urine microalbumin is present, look at the creatinine, it's 35, but see what has happened to it. It's come down to 55, the EGFR. Don't depend on creatinine, measure EGFR. Right? History of myocardial ischemia during exercise, metformin, telmisartan, amlodipine, hydrochlorothiazide, atorvastatin, tolerated doses. So this is the history, right? Let's take this forward. So let's go back to this patient. You tell me. The microalbumin is 9. A1, A2 or A3? Coffee? Okay, less than 30 is A1, 30 to 300 is A2, greater than 300 is A3. Where is it? A2.
Needs aspirin.
Less than.
It's not missing.
So forget the treatment, we'll come to it, right? Let everyone understand that this very concept. Next, EGFR is less than 90, so already it is G2. Less than 60, it is what? G3. So, when you write in your case sheet, what are you going to write? A2, G3. So, A2, G3. Forget the G3A, G3B and all of that. That's at Georgie's level. For us, for simple people like us, this is enough. Can you see where she is? So, already her risk is increased. So, first is, what is the optimum approach for clinical deterioration? Is it worthwhile to slow it down? Does it consistently work with early CKD? Will there be an initial dip in EGFR, which is something we'll talk about? And how should it be done? So we'll go question by question. I have 10 minutes, don't worry about it. We'll go slowly. So what is the optimum approach for clinical clinical detection of early CKD. What is the optimum approach? We already said this. What is it? Everyone should get. Second, what should everyone else get? EGFR. So it's not just the microalbumin. The combination of an EGFR and the microalbumin is the most optimal way to screen for this. Clear? Right? I think we need 4 coffee from the screen. So when to screen? In type 2 diabetes, at diagnosis, remember up to 10% can have established TKD at the time of diagnosis. Then every year. Don't have to do urine 24-hour collection. Don't do protein creatinine ratio. It's all right to do a dipstick. You can keep doing it yearly in the same lab, the same way. You already have your control. Don't worry about it. Spot urine ACR, EGFR. How do you define it? Greater than 30? I would say less than 90 you really need to act. Less than 60 means that there's significant dysfunction. Right. For all of these, we need to start damaging. So all of these is the way in clinical practice. Simply remember, every year you want to do this. What do? Test it. If it is less, start therapy. It's greater than this. So you still need to make sure that you're doing the right amount of glycemic control, that they're on statins. If your blood pressure is high, you still get an ARB on board because you're going to prevent this from happening. And remember, an SGLT2 inhibitor, anywhere across the spectrum of disease, at higher doses, it takes care of your glucose. In the inverse in DKR, it actually helps you. Let's go. Is it worthwhile to slow the decline of function in this case? We were one of the first to start looking at this in diabetes. We had to start trial that actually showed the amount of creatinine in India. But remember that annually in a diabetic, there is a significant reduction in the EGFR year on year. Up to 4.5 is the number that I remember on the top of my head. And the question is, can you slow down that decline? Remember, it declines with age, but there's nothing like diabetes to accelerate this decline. Right? So, if you look at all of this, one is this substantial decline in the EGFR is actually a marker for cardiovascular events. Right? And if you reduce the slope, so it's not just that something causes a problem, but if you treat it, remember, the decline in the EGFR is a marker of something that's happening, right? But there's no guarantee that if you slow it, will it become better? The answer is, if you slow down this decline, it does become better. So there's evidence that there's a problem, and there's evidence that if you address it, it gets better. So many studies have, and you've heard this hundreds and hundreds of times, that have shown that there is benefit. So we know this is Credence, this is Fidelio, this is looking at finerenone, then there's looking at a whole bunch of stuff, and of course now we know semaglutide, it has significant renal benefits. But even if I'm able to get you into some simple principles, I would have earned my money. So let's look at this carefully, or my trip to Trivandrum, which I value a lot more. So these are the 3 pillars. RAS blockade, Dr. Georgie and I are old enough to remember the pre-RAS era, and the first trials showing a benefit with the doubling of serum creatinine. That's, remember, that was the original thing that we talked about, that this came down. Then SGLT2 inhibitors, and now we have finerenone. Now, I just off the top of my head tell you that the greatest, when you calculate benefits, we look at what is called number needed to treat. When you compare use-risk ratio, right, RR. But ARR is what most people don't talk about, absolute risk reduction. Number needed to treat is 1 by ARR. It tells you the number of people who have to be treated for one person to get the benefit. Of these 3 drugs, the greatest NNT, this means the lower the number, is with an SGLT2 inhibitor. That is why many people use an SGLT2 inhibitor as the first drug today in heart failure. And increasingly nephrologists have started believing that it should really be the first drug in renal dysfunction. Why? Why are they doing it? Because the NNT is very low. So does it work in early diabetes? The answer is yes, because how does it work? it works by two mechanisms. How do you improve? You reduce the pressure in the kidney, things get better. So it can work at the afferent arteriole or the efferent arteriole. Also, anything that addresses this reduces interstitial fibrosis, reduces inflammation. Right. So this is the EMPEREX study, which is the first one that showed that insulin nephropathy with worsening goes down, progression to macroalbuminuria. Remember, progression to microalbuminuria can be up or down, but jumping from micro to macro came down. But the most important is always this. Now we talk about MAP, multiple, that is, just like MACE we have MAP, but remember this is important. So when you start this, there is a significant reduction in the time taken for doubling of serum creatinine. That's really why we use these drugs. And of course, for any time, we've always talked about cardiovascular benefits. Remember that these compound. Again, I won't spend too much time on this. So most studies, this is what is happening. So we have studies everywhere, except in ESRD and dialysis. There is data for SGLT2 inhibitors across the spectrum of disease. This is the declaratory, this is the thing, but look at where overall across in diabetics, does it prevent kidney progression? Absolutely yes. We won't again spend time. So this again tells you what is the actual impact of the drug. In these studies, it prevented the use of dialysis. That so many patients did not go to dialysis because these drugs were. That's why Dr. George is retiring early. Right. So, I don't like words like holistic, this, that, but say that. But we want to provide good metabolic care. Think of the heart, think of the kidney, think of the liver, think of the brain. And first line is lifestyle, but in most patients today, even if metformin is not used, they may still be candidates for SGLT2 inhibitors. That's what many of the, for example, somebody established CVD, even if metformin is not used, an SGLT2 inhibitor needs to come first. Second line, of course, today is GLP-1RA. I've talked about. Third line will be the next group that's coming this morning. So there's benefit in progression of CKD, ASCVD, heart failure, glucose lowering, hyperglycemia. So the one thing you want to remember is when you start them on an SGLT2 inhibitor, when you reduce the pressure in the glomerulus, your eGFR will decline a little. There will be a dip. Okay, that's actually beneficial. But how much of the dip is bad? It is more than 30%. Then you need one to think about it. But let's say the eGFR went from 69 to 65. Went down from 69 to 30. You want to think, do they have a renal vascular disease? So that's the one question you want to ask. I want to get into this. So, lastly, how should the review of performance be? Who should be there? These are the patients. eGFR greater than 20. Some people will extend to 50, but greater than 20. If they have microalbuminuria, careful about genital infection risk, combining with DPP4 reduce it. In India, the simplest way I prevent GU infections by telling patients how to take care of the genital. Wash after every use. You go to the bathroom, make sure you keep it clean and dry. Our women are wonderful in making sure that they don't get it. So this is not a big deal. The amputation question has been largely addressed. You really don't have to worry about it. But if you're worried about a litigious patient, if you're at risk for amputation, don't use it. Any of these days are good, use how these are. Hypoglycemia is very low. Remember one more thing. How do SGLT2 inhibitors work? They work by pushing the glucose into the urine. The lower the eGFR, the lower is the ability of SGLT2 inhibitors to push it into the urine. Therefore, at lower eGFRs, their glycemic value reduces. But their renal, heart failure, cardiovascular protection does not reduce. Therefore, we need to add another medication. But these need to be on. I have some colleagues who think that they belong in tap water, but I think they still need to be a prescription. So with this I'm going to stop. I hope this is simple enough and it answered your questions. But I'm more than happy to take your questions and help you out after Nandita finishes. Thank you so much. I really appreciate it.